Hello and welcome, everybody. Today I'm going solo for the first few minutes. Here is Chris Tronsden. We're here
Hey!
I was just ready to do the intro. Would you like to take it away or will I do it for you?
You do it.
Okay, welcome everybody. Today we are here asking the experts. We're talking about OCD and eating disorders. This live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDS online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online by going to www.988lifeline.org. We want to create a safe place, so please be kind and respectful to everyone. At the end of the day, we are all here to support each other. And note that this is being broadcasted on several social media platforms and is being recorded.
Hello, how you doing?
I'm well. How are you?
Good old LA Orange County traffic, shutting down exits, can't get to work. The huge. How are you doing?
I'm well, thank you. No traffic for me. I'm working from home.
I know, I should have just worked from home.
Yeah.
Well, I'm excited to have you on. There's two reasons I'm excited to have you on. First of all, we have kind of like stacked eating disorders questions, and Liz and I have been like, oh my God, we have all these questions we've gotten submitted. We haven't answered them. We should get Kim on the live for that. But also, I had text you, and maybe we'll start here. I had text you. Let me go grab the book. Oh, I always have to support my buddies. Oh. But as you know, Kim has written a book on self-compassion. And I text you because I was speaking at a conference in London, and I can't remember the doctor's name now. You knew it.
Paul Gilbert.
Paul Gilbert. So he really did this whole presentation on self-compassion for body dysmorphic disorder. And I was just like, man, they seem to really be doing a lot more of that over in the UK than I hear us ever talk about here. You're like the only one that I hear talk about it. And obviously, I've recommended your book to clients, and I've worked with clients through the workbook and really have talked about self-compassion. And so what I think I want to talk about before we jump into the eating disorders questions is, and maybe you experience this as well, why do you think people with OCD, related disorders, anxiety, depression, why do you think eating disorders, why do you think there is such a negative internal dialogue? Because I think I see it more in my clients than I see it in my friends who are even hard on themselves.
Yeah. So the thing to know here about the human mind is we often use self-criticism and self-punishment and self-judgment as a way to motivate ourselves towards change. In some ways, that is somewhat effective, especially if a tiger is chasing you down the street or there's something very, very actually like dangerous happening. Your mind will go, run, you've got to get out of here, go faster, and will speak that way to you. And it often does propel you to run away from the perceived or the real danger. If your brain is actually telling you there's danger when there's not, which is typical for anxiety disorders and eating disorders and other OCD related disorders, we often engage in that behavior as a way to motivate ourselves towards change. But what happens is then we rely on that too heavily, and it becomes very habitual, and we sort of desensitize from it so that we're just doing it all day. You know, be better. Don't do that compulsion. What's wrong with you? Why are you having that thought? Why is your body not this way? You should be better. You should be thinner. You should be prettier. You should be smarter. All the things. And we are actually then, it sort of becomes our inner dialogue that goes on all day and all night.
Yeah, I don't know if you see this. We had a discussion in my support group. I run support groups Tuesday and Wednesday nights. In the support group last night, we were really talking. And one thing that people were kind of just having a dialogue about is how much OCD can shape the way you feel and see yourself. And so,
Mhm.
people that had like taboo thoughts, whether that was like scrupulosity or harm, really just were admitting last night that they particularly don't like themselves.
Yeah.
Working with a client right now and just, over the years, her OCD blames her at everything, just
Yeah.
blames her on everything. Like, why did you say this? Why did you do this? A lot of replaying conversations. And people from the group were just saying, like, I basically shifted my whole lifestyle because I just don't like myself. And we got into a big discussion. So I'll toss it back to you just to get your insights and then I'll kind of add what the group came up with. But, a lot of people just ended the conversation just saying, like, I don't really have good self esteem about myself. And I was saying, well, think about it. You're working with a disorder that has you, OCD has you consistently doubt yourself, question your identity, question your intentions. All you do on a daily basis is question, question, question. How in the world can you trust yourself, like yourself, and have self-esteem? So, what are some thoughts that you have
Mm.
around just like after having OCD for so long that people just really, really feel low about themselves?
Yeah, and you hit the nail on the head there with the word identity. OCD and eating disorders really distort our identity and who we are and the way we see ourselves in the world. And I think that a big part of the disorder is when you have a thought like you're a terrible person or what kind of person has those thoughts. When we start to really have those thoughts and treat them as if they are important and need to be responded to, we do internalize this identity that we are wrong, we are bad, something is wrong with us, we are innately flawed and lacking of worth. And as you can come and be and work through those disorders, you can then start to rebuild that identity. Now, you can do that starting today if you want, which is by witnessing and observing what you think and recognizing that just because you think it does not make it true. One other thing to remember here is a lot of people with OCD and an eating disorder or either have secondary depression. And depression also brings a heavy layer of negative thoughts about themselves, about who they are, what the way people see them, what their worth is as well. And so, I think there are many ways in which these disorders can make us lose who we are and our identity.
There's a conversation last night. There's a gentleman in our group. Not everybody in our group sees one of us as a therapist, and he was saying, my therapist is really introducing ACT, and I'm really, really like clicking with it a lot. And somebody else was saying, like, I really struggle with finding my identity, finding my values. They were like, ACT didn't work for me as well because I'm so lost. And what I was saying to them, and what the group was saying last night, is just it has to be something that you explore. You almost have to rediscover yourself. That was kind of the conclusion that we had, is like you have
Mm.
to almost rediscover yourself, not necessarily without OCD, because obviously throughout the stages OCD is going to be present, but you almost have to like figure out who you are without constant obsessions, compulsions, etc. So we were talking about it like one person was like, I don't even know what music I like because I'm so triggered by words that I've avoided so much music for
Yeah.
years that I haven't even like listened to music recreationally. And now that I'm like back into, doing better in therapy, I don't even know like what music I like. And I was like, but that's what's exciting. It's not fun. Obviously, you wish it never happened to you, but now that OCD has happened to you, or eating disorder, BDD, etc., like rediscover, like spend a Saturday like flipping through different playlists on Spotify and just listen,
Yeah.
and come from a place of like curiosity, listen, see what makes you kind of move and what you enjoy, versus, in the past it was scanning for certain words. What
Yeah.
tapping do I have to do in response? So I
Yeah.
think one of the things that helped me in my recovery is like if I can look at reconnecting with my identity as excitement versus terror or fear or exhaustion, then it was something like it was a feeling of growth.
Yeah. I will share this a personal story. I do not have OCD, but I did have an eating disorder. My whole identity was wrapped up in being thin and being the fittest person in the room. They were my disorder had me focus on those things so much, and I had forgotten the other parts of me. They just weren't important to me because I was so hyper focused on these other things being so important. And I had to be quite rigid and repetitive anytime my brain wanted to go, well, you need to be in this body or you need to be this fit. I had to pause and go, okay, catch that. And then it was a very jarring, action to then go, what else can I think about, or what else can I be focused on, or who am I other than that? And that took quite a long time. I would say that was the thing that took the longest to change. Even when I was at the end of my recovery and I was weight restored and eating better and exercising less, that identity piece, I still to this day, every now and then I'll catch myself and be like, wait, like, uh, go back to exploring that curiosity on, like, who are you besides those things. I think that that's very true for both disorders.
Yeah, I'm glad that you brought that up, and I want to talk about this real quick, is because there's different unique challenges people have throughout their recovery journey in any disorder. And one thing that I have with my clients who are getting better with OCD is they'll say to me, they'll say like, Chris, if I was like standing in line waiting at 7-Eleven, if I had a doctor's appointment and I was like waiting in the lobby, I was never bored. I always had something to ruminate about. So I was replaying things or whatever. And they're like, now that I'm better, I sit there and it's like, I'm like waiting at the DMV or something, and they're like, I have to like be on my phone or something because I don't even know what to think about.
Yeah.
My mind just goes blank. And I was saying to them, and I wonder how you feel about this. I was like, that's why to me, like there's certain parts of treatment that we don't talk about as much. And one thing I talk to all my clients about is like finding a hobby,
Yeah.
connecting with people, volunteering at an animal shelter or somewhere else, getting a job, going back to school. Like that is part of your recovery. Because I know when I'm bored, like waiting in line or stuff like that, I have so many things I'm interested in. I'm fantasizing, thinking about something, planning something later. I'm never bored in my head, but I do remember that process. Like once you go from like not ruminating and being in mental compulsions all day to nothing, people are just like, oh my God, what do I do with the free space?
Yeah. Yeah. Yeah, and I think that, I mean, for me, it was exactly that, is I actually had to sit down and really discover and actually rehearse another identity, which is like, you're not your body, your worth is beyond what your body looks like. I had to sort of do some rehearsing, not in a compulsive way, but sort of in an affirming way of, these are the new core values I'm choosing to believe, even if it doesn't feel like I believe them yet. This is what I'm sort of training my brain to remember that I'm more than these things. And I think often for people with OCD, I've had clients with the same thing, is they'll say, I used to love band and I used to love track, or I used to love art. And sort of, even if you don't love it now because OCD's taken that, you can also sort of go back to those things and be curious about those things and sort of start to remember those things about you.
Yeah, no, I hope what people are getting from this conversation is these are just what I usually like to bring to these live streams is like, what are the things that I'm hearing from clients or what I'm hearing from like emails I get or like Instagram private messages. And those are some of the things about just like, how do I reconnect with myself? The other thing I really want to point out to people is in the past, when we've had these discussions, they've fallen under kind of like the life after OCD treatment categories. But what I really want to say to everybody is like, this can happen throughout your recovery process, whether it's body dysmorphic disorder, depression, eating disorder, obsessive compulsive disorder, skin picking, hair pulling, all the things that we talk about, hoarding disorder. There's this belief that it's like, okay, I can only work on the obsessions, compulsions, and then I can reconnect. And I think that what I always tell my clients is OCD treatment, when you engage in exposure response prevention and the adjunct treatments we talked about a second ago, you should be learning, you should be discovering, you should be opening up possibilities, you should be reconnecting with yourself, your environment, your friends. And so if you're finding that you're doing great treatment with your provider, but you're still not really leaving the house much or connecting with people or doing hobbies, don't think of that as fluff. That is part of the treatment. You've got to find things in your life that are way more important than the disorder.
And that was the case for eating disorder recovery as well. So for sure.
Yeah. So what I want to do, we got a bunch of pre-submitted questions. I want to jump to a live question first, and then I have a eating disorder question after that. But for Braniel M at 9:11 a.m., that's 12:11 your time, Brennan. I have false memory OCD from last year that I harmed my 6-year-old nephew when I dropped him to his house on the motorbike, and he was sitting behind me. And it sounds like trying to get clear thoughts, doing compulsions. One thing that, I saw a talk on perfectionism. There was a OCD conference kind of happening at the same time in London, and I went to it. And there's a talk on like OCD. It wasn't a conference, but it was just a presentation. But they were talking about OCD, and one of the conversations came up about false memory OCD, past memories, real event OCD, and they were saying is like the more you check, the more you doubt. So I'll just kick it off to you, but that's what I always think about when people are trying to remember past events. It's like the more you check, the more you doubt.
Yeah.
What are some thoughts about false memory, specifically maybe what Braniel's going through?
Yeah, well, and I think that the thing with false memory OCD, it's funny, I just got off a call before this on treating someone with a very similar case, is the more you try to get clarity, the more you're hyper aware. And the more you're hyper aware, the more you're going to notice other details in that memory, which are only going to create more uncertainty because now you've got more data to try and make sense of. So agreed, like a huge part of the treatment for false memory is catching. You're an attempt to try and get clarity of that event and trying to get clarity of what actually happened. That, again, I always do an experiment with clients where we have a whiteboard in my office and we write our name, right? Even if you just write your name, you could even do it right now if you're listening. And if you stare at your name for long enough, it starts to look very strange. And then you're like, is that even my name? Is that really even how I spell? Anytime you look at anything for too long and examine something for too long, it gets distorted, which is just going to trigger you more. So absolutely, we've got to work on that response prevention with that type of obsession.
Yeah, there was a really good study that I have bookmarked on my computer, but they looked at people with OCD. And I think the reason that people check so much is because in real life, that's how you figure things out. If I want to be an expert on Greek mythology, right? The more I read, the more I learn. I go to Greece, I go to the sites of Athens and all that stuff. The more I become an expert, the more you and I get trainings and speak and go to events around OCD and related disorders, the better of an expert we become. So it's obvious, Braniel, why you're taking that step is it's like, oh, in other areas of my life, the more I think about it and focus on things. But the problem is, I told everybody in group last night, you guys are coming to me, people with health OCD. I'm not a doctor. So when people make an appointment with me, if you really thought you had a health issue, you wouldn't come see me. You'd go see a doctor. If somebody's really struggling with scrupulosity and they really think that it's religious, don't come to me, go to a pastor or priest. But the reason you guys come to these lives and you talk to us is because something isn't right. There's something different than it being accurate. And that's the problem, though, is like that curiosity is being almost like manipulated by the OCD. If I just keep thinking, but the research is very clear that the more you do that, the more confusion. So I always say compulsions equal confusion.
Yeah.
So the idea of kind of letting go of trying to figure that out is going to feel so hard, and it's going to feel irresponsible. But you have to release to get clarity. And that's what I tell people. Take that step back, step away from it from a little bit. Like Kim said, practice the response prevention. And what you'll start to notice is you'll become clear the less you do.
Yeah.
For sure. I want to throw it to one of our eating disorder pre-submitted questions. So it was, I put it in the private chat so you could put it up, Brennan, but I have a 16-year-old daughter who has been diagnosed with an eating disorder and OCD. She plans out her meals 2 weeks in advance. Should I let her have control or should I step in? What is the best action to take?
Yeah. So I think the answer here is it depends on if she's in treatment or not. If she's got a treatment provider, I would take that information to the provider and they together can make a decision on which step they take first. Similar to OCD work is we work in steps with recovery. So for some people, let me go back to that question so I make sure I get it correct, is if she's planning it out 2 weeks in advance, maybe they could agree the first step is to reduce it to 1 week or to reduce it even less than that over time. But you're asking if you should step in. Sometimes this is true for OCD as well. You step in, they just find another compulsion to do to get that certainty or to get that, a lot of times, even in eating disorder recovery, when you're in an inpatient facility, they might plate your meal and put it in front of you. if they're not invested in the treatment, they might find a way to like stick that food in their pockets and not eat it anyway. So I think the main thing here is how are you having conversations around how willing they are to get better? Do they understand that the planning, do they have this understanding of how the planning is making the disorder worse? For some people, I will even go as far as saying is planning meals is a safety behavior to reduce anxiety about weight. Um, it may be that treatment is that they continue to plan, but we focus on weight restoration first as the most important thing. And so we let them have the planning, but we work at increasing food intake first, particularly if they're very malnourished. So I would say your work is really to talk to them more about their willingness for recovery than to take this behavior away, because that may not, they may not be someone who really enjoys that or appreciates that or even follows along.
Well said. Thanks, Kim. I do want to put up a comment from Beth at 1216 Brennan. Beth has been somebody that I think of a lot because Beth has come to the support to the live streams for a while. And Beth was really struggling just leaving the house because of COVID. And Beth wrote at 1216, I finally came out of my comfort zone. I went into a grocery store for 5 minutes. I go on walks. I went into PetSmart for 20 minutes. 3.5 years of hiding from the pandemic. Went to my ex-boyfriend to care for the cat. Like, how awesome is that? I mean, one of your, I always think of one of your, like, kind of like Kim Quinlan catchphrases, right? Is like, it's a beautiful day to do hard things. Seeing that, I hope other people are inspired watching this. Why is it important for someone like Beth to push herself and to really do the hard things and to have these positive outcomes?
Right. Beth, I celebrate you. Oh my goodness. I love hearing these stories. And I want to really highlight Beth is doing these huge things that may feel small to other people, but they're huge things for her recovery. These are massive steps for her recovery. Chris, tell me what your specific question was there, or did you
Not
not
really a
have?
question. I just think, like, how can other people be inspired by that? I mean, that's why I like support groups. That's why I like live streams. That's why I
Yeah,
like the community, is because there's going to be other people watching this who are in Beth's situation. It may be about COVID. It may not be about COVID. It could be about anything. How can people be motivated by people like Beth doing those hard things that you always talk
yeah.
about?
I think the thing here is these small baby steps, when we take them, they feel so insignificant. And we often judge ourselves like, this should be easy. Everybody else is going to PetSmart. Why can't I? But then you do it. And then you have this learning of, I did it. There's a learning that happens. Wow, I actually was able to do that. What else can I do? And for everybody else, those small baby steps is where we gain confidence. It's where we start to get our identity back. It's where we start to see, like, I'm actually more resilient than I thought. I actually can handle a large degree of anxiety and uncertainty. That opens up this sort of conversation in our mind of like, what else can I do? And anybody who has a mindset of what else can I do can go as far as they want. And so I think that those things, I just would say, use Beth as an example of, baby steps equals medium steps equals humongous steps. This is so exciting.
I am excited for you, Beth. Thank you for sharing. Okay, I have an eating disorders question. Someone who obsesses about calories of anything they eat, the number of calories per day, how many calories are burned for specific amounts of time of exercise, and the type of exercise. Would this person get a dual diagnosis of OCD and orthorexia?
Right. So, just to be clear for everyone listening, so let's sort of just differentiate the differences here so everyone knows. So, we know with OCD, there are obsessions and compulsions that occur. The compulsions can be physical or mental or avoidant behaviors. With orthorexia, it's very similar in that it's around the cleanliness or the purity of food. So it's similar to contamination OCD, but it's actually around food. So it's, is this food clean? Has it been, is it got pesticides in it? Is it, they're often then will do avoidant behaviors of reducing the intake they have in fear that it will make them sick, or that it's not pure, or that it will contaminate them. Then we have eating disorders, which is more like you've listed: preparing, ordering, counting bites, and others. If you're doing those behaviors to reduce the contamination of the food, or the impurity of a food, well, then yes, it would be related to orthorexia. However, if you're doing those behaviors to eliminate and reduce your body weight or body mass or body size, it would be better understood as an eating disorder, whether that be anorexia, which is restriction and there's restriction and purging style, or bulimia, which is all purging. And there are other smaller areas of eating disorders as well. And so you've gone through here, again, we'll go through them. Counting calories, the number of calories, talking about burning calories. We would really need to know what is the reason for doing that. What is the core obsession in order to make that differentiation of diagnoses? It could be that it is both. We have had clients where they're reducing and restricting calories because they want to lose weight and be in a certain body weight or size, but they're counting to these sort of good numbers, like safe numbers. And, I have to have calories that only are within these numbers because there's these good and bad numbers, or certain foods are immoral and there's a scrupulosity OCD involved as well. So it can be both. We would need to understand more about what is the core fear there to get to the bottom of the diagnosis.
Yeah, I had really bad orthorexia when I was running gyms. And it's like, what's also difficult about, perfectionism and eating is that people were so proud of me. They're like, dude,
Mhm.
you are so good at eating clean. You're not tempted at all. And I think that's what's hard in all of these disorders, right? Like with BDD, if you're doing all these things to look a certain way, you might get compliments. If you're eating a certain way, you might get compliments. If you're doing compulsions around perfectionism with your schoolwork, right, you get accolades. So I think that's what's always tough sometimes with these disorders, is sometimes you get praised by other people, and it's like,
Right.
oh, it just kind of feeds it.
Yeah,
I wanted to
exactly.
bring up a depression question because we talked a little bit a second ago about secondary depression. So at 12:16, Isostasia said, I feel depressed because I cannot be a normal individual, can't live a regular life, achieving goals according to my age, etc. So we know with OCD, but with all these disorders, people feel behind. They feel disconnected with their values. They see sort of their life pass by, or peers hitting different markers. What are some words of encouragement for people that feel that way, and how can they address that so they can feel better about their current situation?
Yeah. So, number one, I think that, again, as I said at the beginning, depression tells so many lies. And I think first we have to acknowledge that the diagnosis of depression, a part of that comes with having really negative thoughts about myself. Now, I've had clients who've said the same thing. I'm not normal. I'm not living a regular life. I'm not achieving goals, but they are actually out going and doing all these things. It's just that depression is telling them it's not enough. Then there are also people who are depressed who are in bed all day and aren't able to live their regular life. So I want to be really careful here, because there are those who are struggling to get out of bed, but there are those who also who are going out and living their life, but still depression is telling them it's not enough. I think either way, we have to be able to identify those thoughts and recognize that you're handling something incredibly difficult here. First of all, we know one of the best things to do for depression is find a community of people or a support group, whether it be a support group like Chris is talking to, a therapist who can help you identify these thoughts and even first check, are they accurate? The second piece is, what baby step can you take? You said can't live a regular life. What would that look like for you? What kind of life do you want? And we can reverse engineer that. What would be one baby step towards that today? Let's give ourselves radical compassion that it might take some time. What are these goals that you have, and how can we reverse engineer that? Meaning, what are the first baby steps you can take towards doing that? Maybe your goal is to, um, you know, get a certain job or go back to school. Okay, what steps would you need to take? Maybe the first step is just researching. Maybe the first step is um, finding somebody else who may know something about that career or so forth. So take baby steps, but do find support, because depression tells nothing but lies.
Yeah, and what I want to say too to add to that is like, when I've had people in my life, whether it was cancer, whether it was like back surgery, whether it was like a injury or a car accident, we all gave them the space to recover. We all
Mhm.
supported them. We were never looking at their life and saying, why are they behind on this, right? For some reason, when it comes to mental health disorders, maybe it's just because these are the ones I treat, but I feel like specifically to the ones that we're talking about today, there's this belief that we're supposed to be able to balance like a very extreme mental health condition and meet all of quote unquote society's markers. And it's like, we got to be easier on ourselves. I mean, yes, it's very hard. I remember those thoughts when I got better from OCD. I fell into a very deep depression because I went back on social media, and all the people that I used to hang out with were living a much more robust life than I was. The only thing that helped was to give myself some understanding and to say, look, like, you've been on a different journey than them. It's not better, it's not worse, it's not right, it's not wrong, it's just simply is. And if you can get back onto your correct path, away from what these disorders have taken from you, whatever you get to, you'll get there. But you can't keep looking in the other lanes. You've got to focus forward. I love the quote, like, chase the dream, not the competition. And I used to keep, if I was ever going to get a tattoo, I think that's what I would get, because I love that statement, or that quote. And it really helped me recover, because I would remind myself, like, I can't be looking on social media every day and seeing what friends are doing. I have to focus on my recovery. So I think that's important to remember as well. We have another pre-submitted eating disorders question that says, I have a lot of just right and perfectionism symptoms, and I also have rigid rules for eating. So obsessing for preparing, ordering, counting bites, and many others. I've been obsessed with eating my whole life, but not known if it was an eating disorder. I still think not, but luckily ERP is working for all my food obsessions and compulsions. So I
Yeah.
think there's two parts in there. Is like, how do you navigate if it is or not? And then if ERP is working for this person, is that something that they can do towards, difficulties that they're experiencing?
Yeah. I think that the truth here is, it doesn't matter what we call it, whether we call it an eating disorder or not. It's identifying whether these behaviors work for you or not, whether they're helping your life or not. And it sounds like you've identified, you identified like they were mostly related to just right and perfectionism, and these overlap a lot. Actually, I wrote down a couple of statistics just because I think it's important. So we have evidence that up to 48% of people with OCD have some eating disordered behaviors. That's significant.
Mm.
And so I think here it's important that us we sort of validate that, yes, it's important to get a correct diagnosis. But what's more important is for you to decide for yourself, is this helping or hindering me in the dream that Chris was just talking about? So it sounds like you've said you've identified rigid rules, obsessions for preparing, ordering, counting bites, and so forth. And it sounds like you've identified that, you know, I would like to change these. And that's really all we need. That's the most important. Now, to look at the ERP, absolutely. ERP is very beneficial at treating eating disorders, particularly around these sort of themes of rigidity and rules and so forth. And so, even my treatment, it's funny because I love using ERP. I was treated for my eating disorder. I was actually doing ERP, but they just didn't call it that. She was like, "You need to go and eat a burrito." And I was like, "I'm not eating burrito, no way." And she's like, "Okay, I need you to go and eat a burrito by the time I see you next Wednesday." That was exposure. That's what she was having me do. She was like, "You need to eat the fettuccine Alfredo." And I'm like, "But I don't want to." But we did. And so I think that ERP is a very crucial part of seeing that you can tolerate changing the rigid rules of an eating disorder, whether we call it that or not. Hi, Liz.
Hey, Liz.
Oh, sorry guys. I promised it was a good cause. It was another talk, but sorry. Here
No,
I
no
am.
problem. It's great to see
No, it's
you.
all good. It's good to have you. I was going to throw up. So I've been kind of going back and forth. We've had some questions on eating disorders, depression, OCD. So kind of throwing it all in there. We have a good question at 12:24 your time, Brennan from Chantel. She says, I have a question. I have had a few themes in the past, and I've made some really great progress with ERP. Congrats. But one that keeps coming up and not sure how to do ERP for is hyper awareness or obsession of my tongue. It sounds weird, but having my daughter, I had a sore mouth because of med change, and I became obsessed with how it felt. And the more I obsessed, the more it felt swollen and sore. This has come up in my recovery, and I haven't obsessed about it for so long, but OCD is trying hard to get me to obsess about it again. So, I think this is one that sometimes we don't talk about as much, kind of that sensor motor, focusing on things like our tongue, our chewing, our blinking, our heartbeat. So I'll let either of you jump in. It sounds like Chantel's had really great success with ERP and now is struggling a little bit on the fixation of the tongue.
Liz, do you want to take it?
Happy to, yeah. So this is really interesting just because I think sometimes there's a lot of overlap in like health anxiety, OCD, and people kind of get stuck and struggle with like, how do I differentiate? What do I do? But what I want you to recognize is that we want to treat it the same way, right? So of course, first and foremost, we want to get things medically evaluated. So if there's something going on and there's a medical concern, and I always say like we do that once until unless the doctor tells us we need to do something else, we do it once to make sure there's not something we need to do. But otherwise, we treat it as OCD. So when you think about OCD from a standpoint of if someone has a fear of STDs, right? If they have this irrational fear of STDs, they'll also talk about body sensations and scanning their body and feeling when they have a tingling or any sort of sensation that was actually a normal sensation, but now they're hyper focused on it. And so what we need to do is we need to, first of all, really start to think about what are the things you avoid and what are the rituals, which the rituals include body scanning, body checking, thinking about how it feels, thinking about that sensation. But then when we add in ERP, we're going to intentionally ask you to start like evoking that sensation or tolerating the distress of the sensation being there and choosing not to do anything about it. I think a lot of times where people get confused is they think, oh, well, an exposure is me just like eating food. And when I have the thought that my tongue is sore, pushing that down, where it's like, actually, like that's a suppression model, right? And that is going to increase your anxiety or distress. And so we want you to actually purposely think about like, oh, my tongue feels a little sore and I'm still going to choose to do this today and like not figure out where that's coming from, right? Can you tolerate the distress and the discomfort? And as you'll hear, the themes Kim and Chris and we all talk about over and over are, can we learn to just tolerate discomfort? Right? Denise Ian Stack's quote is like, can you be comfortable being uncomfortable? Right? Those are the main things we really want to teach you.
Yeah, one of my clients is a surfer, and he said if I was to he's a teenager, so but he was saying if I could sum up like OCD treatment, it's like whatever I'm resisting, I got to go into it like you do the waves. And I think of it for that question is like the more we try to resist thinking about it, feeling it, it's really that conflict. It spikes the part of our brain where OCD impacts, and it keeps us attuned.
Yeah.
The next pre-submitted eating disorder question, I'll toss it to you, Kim. Can this rise out of or in conjunction with health obsessions? So it sounds like the person who submitted this question says, my teen grandson has OCD around health obsessions. Now he won't eat anything unhealthy. He also has to exercise a lot. He has a timer on his phone to remind him to get up and exercise. So how do you navigate? I think that's a good question of like, can it be all related to OCD and health? Could it be a separate thing? Doesn't necessarily matter. Like, what's the process if this person was getting assessed?
Yeah, so similar to the last question we did with this is it very much depends on what is the core fear. If the core fear is what if I get unhealthy and I die or whatever that be, well, then we would understand it through the lens of health obsessions. But again, often there is a dual diagnosis here. It could be that this person has health anxiety and what we call eating disorder NOS, which is not otherwise specified diagnostically. Some people have the fear that, again, they said that they're not eating anything unhealthy, but they also have this goal of being thin and very much focused on the size and shape of their body. It could be that they have health anxiety and eating disorder or anorexia, or if they're binging and purging, bulimia. So again, I think it depends on specifically what is the core fear, what is going on. It could be one, it could be multiple things. It isn't uncommon for people to have health anxiety and OCD and an eating disorder as well. So I think it's important here that you get a thorough assessment. That will then, if once we know that core fear, that will then allow us to be doing treatments specific to the fear that and the obsession that's experienced by your grandson, I think they said.
Yeah.
And yes, so and that could be true for, again, like we mentioned before, orthorexia as well.
I'm going to throw this next comment to both of you because I don't know how you all feel. I think OCD specific therapists are the best to handle addressing negative thinking and negative attitudes because everything else to me feels like fluff. So I'll put the comment out, and then I'd love to get both of your opinions. But Nathan at 1233 says, I have a negative attitude for as long as I can remember, but I'm getting better at thinking on the positive side. The reason I really wanted to bring this comment up is like, I don't know what it is, but I have a lot of clients that will read, like, they'll find a book at Barnes and Noble. There's so many podcasts on like positive thinking and manifestation and all of that. And everybody, even people in my life that don't have OCD, but do it for just general better thinking, are like, it doesn't work. But when I work with clients, they do find themselves starting to shift that negative perspective. We talked earlier, Kim, about your book. Liz, you need a book so I can be that. I told John Hirschfield and Kim, I'm like, I'm going to be your obnoxious like friend that always promotes. So Liz, you need a book. But my point is like, how like Nathan's comment at 1233, we were talking earlier, Kim, before you came on, Liz, about just how a lot of people with OCD will have such internal negative dialogues. Like, how do people get better at kind of having a positive attitude and a positive thinking that isn't that like new age fluff? What do you both work on with your clients?
Well, I personally, and you guys might have a different way of looking at this, but I actually don't do a lot of positive thinking. I do more rational thinking because, and I use it as a stepping stone to then doing positive thinking. So, in my recovery, if someone had have said like think positive, my brain would be just like, it wouldn't land ever. It would never land. But if someone said, what is the actual truth? Like, what are the facts here? I could land on that. And then from there, they would say, is there any potential that it could get better for you? Is there any potential that there could be movement in the positive? And that really opened up this sort of idea of curiosity and hope for me. But I had to first, before I went from negative to positive, I had to land on facts and what is true and real. And that was a big piece of the work for me.
Yeah. I don't know if you want to add anything, Liz, about, we were talking earlier about just like, how do people, after kind of going through bad bouts of OCD and depression, like how do people like just, we'll ask you as a personally, like after all the hell that you went through, like how did you land on your feet and say like, I want to treat this disorder, I want to run an institute, I want to get married, I want to have kids? I think a lot of people were talking earlier from a comment, they just feel depressed. They find it hard to do all that. How did you get into that mind space to do that?
Yeah, it's a great question. And I think the thing is to remember is that the approach is actually the same, is that after OCD, it's not like I just all of a sudden felt great and had this positive attitude. I started acting differently and then my mindset changed, right? So I wasn't necessarily like, I want to get married, I want to have kids, this is all going to be wonderful. It was like, oh my gosh, what do I do? How do I do this? It felt overwhelming, but it was really like one behavioral change at a time, right? Like, okay, I want to work in this field. I need to go to school. I need to get a degree. Then I need to get a job. And then I worked my way up. And then, and then I start dating. And then eventually I find the right person, right? Like, so it's not, I just want to be clear that like, these things don't just happen overnight. And sometimes, again, just like with OCD, you don't feel like doing the exposure, but you do the exposure. And oftentimes more than not, you're like, oh, that was better than I thought. Behavioral changes become the same, right? So we feel like we don't want to do these things. We feel depressed, but we're actually not going to feel less depressed if we just keep thinking about it. Like the way we're going to feel less depressed is to do something different about about it to start making a behavioral change.
Absolutely. I'm going to throw the next question to you, Liz, and then the following question's an eating disorder for you, Kim. First I want to shout out Summer Contreras, who's on the live right now in the comments, a fellow IOCD advocate. We got to see her on Monday, and she's down here in San Diego. So hi, Summer. A LinkedIn user said, I've had OCD since I was a child. This is at 1243 Brennan. I've had OCD since I was a child, and it's finally well controlled. However, the two things I can't shake is pulling hair and scratching bumps on my legs, and strong food aversion, like a real bad phobia. Any advice on the leg issues, and would the food phobias be considered eating disorders? So I'll let you both weigh in.
Yeah, so I'll let Kim weigh in on the food phobia and kind of those aversions and how to deal with that. I think as far as the hair pulling and potentially skin picking or excoriation, if that's what's going on with like feeling bumps and having the urge to pick, there's really specified treatments for what we call BFRBs, body focused repetitive behaviors. Some of these treatments that are really effective are treatments like comb, and there's some other interventions as well. But I would encourage you to watch some webinars and to find a provider who specializes in that arena. We don't necessarily use just, I would say, standard ERP, right? It looks a little bit different. Same with BDD. Like, yes, we're using ERP intervention. Same with eating disorders, right? You might use ERP to a degree, but it looks a little different. You might also be adding in some thought challenge worksheets or doing some much more like self-worth and that sort of work that might not be as needed during a standard OCD ERP process. But again, it depends on each patient. And so if you're seeing an OCD specialist, often OCD clinicians also specialize in BFRBs, but if not, you'll want to find somebody who really does so that you can do some specific work for that arena.
To add on to what you said, Liz, real quick before you jump in, Kim, one thing I really encourage you who asked this question, everybody else, is if you have skin picking or hair pulling, tell your OCD therapist. I've had so many clients get better, and then they'll say to me like, yeah, no, I feel better, but I just can't get over the skin picking. I'm like, why didn't you tell me about it? We could work on it. They're like, oh, because you treat OCD. And I'm like, but it's an OCD related. I've gone through so many BFRB trainings. I would love to help you. So please, please, please let your OCD therapist know. I didn't mean to cut you off, Kim. Sorry about that.
No, not at all. It's a really great point. So when it comes to food phobias, again, we have to first look at what's going on again with the specific function behind that behavior. So I'll use me as an example. So when I was in the thick of my eating disorder, I avoided fat, anything with fat, like the plague. In my mind, if it had fat in it, it would turn to fat on my body and I would avoid it. And of course, the treatment for that was me to slowly introduce fat into my body, mainly because fat is very important and we need to have fat as a part of a healthy diet. So for me, yes, that was considered an eating disorder. However, there are other reasons that people have food aversions. Sometimes it's the texture. Sometimes it's the fear that certain foods will cause them to vomit in the case of emetophobia. So we really want to first understand what it is that you believe about the food and why it is that you're avoiding it. In terms of advice, we often use an exposure and response prevention model for that. The first thing to know is, are you avoiding it and is it impacting your functioning? Some people, like my son, hates tomatoes. He doesn't like tomatoes. I'm not going to make him eat it. He still has a really great diet besides that. So it's not something we have to target, really, really strongly. However, if it's a food group, or if it's meaning that you're becoming malnourished or that is impacting your health, well, then absolutely you would talk to a clinician and work towards baby steps towards implementing and introducing that food group or food back into your diet.
Well said. I've eating disorder question for you, Kim, and then an OCD one for you, Liz. My dietitian says I don't have orthorexia despite my obsession with clean eating because my concern is not about health. I told her the concern is a bit of both image and health, but she says because I don't get all my nutrients due to my very specific diet, my concern can't be health. I've tried to explain to her that orthorexia does involve that paradox, and by her reasoning, no orthorexia would have orthorexia, despite being perfectly within a healthy range. So I guess the question there is like, she feels she has orthorexia because it's a lot about image and health, but the provider is saying no because it has to be around like your concern can't be about health. So how like who should somebody see for this? How does somebody kind of parse out what's really going on underneath?
Yeah, so if you're feeling the unseen and unheard by your dietitian, it is okay to get a second opinion. Couple things here. It sounds anytime a client tells me that they have obsessions around health, the cleanliness of food, we would assess for orthorexia. I think that you're right in considering that. It sounds like there's also someone in this case you're saying it's also around your body image, so it could be the case that there's both happening here. The other thing to know and think of, and this is not specific to you, this is very general, is um, when you have an eating disorder, and I'll speak of myself because I don't know you, is we can be really tricky. People, I was very protective of my eating disorder. I would fight my therapist on, like, this is not my eating disorder, and she'd be like, yeah, I think it is, and I'd be like, no, it is not, and she'd be like, yeah, I think it is. And we had this beautiful relationship where she was able to call me out on things a little bit here. So in one way, I would talk with your dietitian more and express your concerns. Could it be both? Could it be both orthorexia and an eating disorder? What are the differences, and how is that impacting? Is this conversation impacting my health, in my recovery? At the end of the day, again, I say to my patients, we don't have to spend too much time getting it specifically correct. Really, what we want to look at is what is happening in your daily life behavioral wise that is impacting your ability to be a highly functioning person that's living according to your values. Can we just target that instead of getting too caught up in what it is? But again, I want to really offer you support that if you don't feel like the dietitian understands your case, it's okay to get a second opinion.
Well said. Liz, I'm going to throw Stacy's question. It's at 12:43, Brendan, if you could put it up on the screen. She says, I have OCD and some depression lately since my OCD flared. ERP works for me in some areas, but in the main area, it's related to specific trauma related to severe medication reaction that lasted 11 months. ERP does not work for it, so now I'm doing EMDR. It seems to help better, but it's still here. My fears about being around anyone with medication. I've read that for people with PTSD, they do better with EMDR related to OCD involving a specific trauma. So, kind of, it sounds like what's going on is like she experienced a trauma with a really bad medication, severe reaction for 11 months. So, there's some trauma around that, and ERP wasn't working. So, she's doing EMDR. What should somebody navigate if they've been diagnosed with both OCD but also PTSD?
Yeah, so I really want to spend some time differentiating both, Stacy. I think candidly, feeling like, oh, I have the fear of being around anyone with medication. My question is like, has that morphed into an OCD fear, and is that now OCD, or is it still very clearly more in the PTSD realm? Because we actually do want to differentiate what those are, because ERP will still work for OCD even if it was started as PTSD, if the PTSD has been addressed. EMDR does not work for OCD. So if you feel like, oh, this is OCD now that's related to the trauma, like, we would not recommend EMDR for OCD. That is not an evidence-based intervention. And so I say all that just to say that with a really good clinician who can differentiate OCD and trauma, we should really be helping you say, okay, what happened with the medication response? And it sounds like it was a traumatic experience. Does it meet criteria for PTSD, or does it better meet criteria for OCD? And depending on, or both, and depending on what that is, if it's both, we want to do specific trauma-related interventions for trauma and OCD-specific interventions for OCD. But if it's better understood as one or the other, we want to do those specific interventions. So EMDR, for those who are listening, can be a intervention for trauma, and there is some evidence and research that shows it's effective. Also, cognitive processing therapy and prolonged exposure are the other two evidence-based interventions for trauma. But for OCD, none of those are evidence-based. So for OCD, ERP would be the evidence-based intervention.
And can I quickly just add, and by no means it's a plug, it's just to help this person. So this Friday I have a podcast called Your Anxiety Toolkit. We have Caitlin Pinciotti, who is a trauma specialist, speaking exactly on this exact thing. It's ironic that it's happening, but so that's coming out, and we actually have Sharla Nicely, who's talking about her own lived experience of having post-traumatic OCD and how actually COVID and events during COVID really triggered her OCD to be flared from a previous trauma. So if that's helpful, it's going to be speaking with a trauma specialist who goes deep into that as well.
And Caitlin also has an amazing worksheet that helps you differentiate trauma versus OCD that I definitely recommend using, and we can add that on. And then we've done some specific webinars on trauma and OCD, so you can check those out as well.
Yeah.
I'm going to try to sneak one more in, Kim, so we can get to as many of the eating disorders. Someone asked, can you speak to a compulsion of not eating? This was a long question, so I kind of cut it down, but basically a little background. Their daughter was in eating disorder treatment for a long time, but finally got OCD treatment. And it seems that this was more OCD. Like there was a compulsion of not eating. There was like a lot of hand washing and cleanliness. So it sounds like the avoidance of eating was due to contamination and not eating. So they didn't do really well in eating disorders treatment. There wasn't any OCD screening process for the EDT. And it was such a focus on getting weight restored that the OCD was overlooked. So can you talk about that? Because sometimes it makes sense, right? If someone's not eating, they should go get eating disorder treatment. But this is a perfect example where it might not be ED and it might be more OCD focused.
Yeah, in a perfect world, both would be addressed at the same time. So again, we want to look at why are they not eating? Are they not eating because they're afraid of the contamination of the cooking and preparation? Or are they afraid of the contamination? Often people don't eat because they don't want to deal with feces and urine. And that's very much understood under contamination obsessions. So again, we want to get to the bottom of like, what is the function behind this behavior? What is the obsession behind it? In a perfect world, both would be treated, but it's important. A lot of OCD treatment centers will not take patients until their weight restored. So they do have to be in an eating disorder clinic or something like that, which is really hard on that person because they're surrounded by other people who are more focused on body weight, size, and shape, and they don't feel like they belong there. That's not the obsession behind their compulsion and their avoidant behaviors. Ideally, both would be addressed, but that's often, we don't live in a perfect world. The good news is it sounds like they have gotten to the bottom of this and where they are, looking at the OCD treatment now. If you can find a treatment facility or a treatment team that can do both, that would be ideal.
Yeah, that's always the dream, right? I think the same with PTSD is like if you could find someone that treats. You can't hear me?
No, Liz, I couldn't hear you.
Sorry, I was popping in, but I just want to say two things really quick. I know we're a little bit over. Kim is 100% right. This is so important that you think about, can you find a treatment team? And a lot of programs like our program, we treat both. We see it all the time. What I will say is that, and I just want to give a quick plug, there are also medical doctors whose specialty are eating disorders. And this is so important, you guys. Like a lot of times we'll have patients will say, oh, well, I'm medically cleared, but it hasn't been by an eating disorder specialist. And eating disorder specialists are looking for certain blood levels. They're doing blood pressure, both laying down and standing up. Like they're doing specific things to really make sure there's not concerns we might not be aware of, right? Refeeding and all sorts of different things we need to think about. But in our program, we see this all the time. And we have had multiple patients who are in our program and they're cleared and they're safe to be in our program, but they're seeing an eating disorder specialist and a nutritionist at the same time to work on that. But what we found is that their eating disorder is all based on their OCD. And so again, the question is, what is driving the eating disorder? If you're not medically cleared, of course you have to be at a medical facility. But if you are, and it's OCD driven, you need to be with an OCD specialty team, but make sure you have a medical team to maintain safety and stability. But if it's eating disorder driven, right, you're going to do eating disorder work first. So really important to differentiate and to understand that there are even medical doctors who specialize in eating disorders.
Well said. What I want to do in the final moments is give each of us a final thought. So we'll start with our guest, Kim. Any final thoughts just on, we talked, you know what, I was thinking about this. I was like, I really like today's live because we addressed so much. We talked about like self-compassion, negative thinking, depression, eating disorders, OCD, skin picking. Like there was a lot we talked about. Any kind of final thoughts that you have for everyone to leave them with?
No, I think the main thing is, again, baby steps here. Again, first of all, a lot of the questions involved getting a correct assessment. And so I sort of want to highlight that. I think that is a really important thing when we're talking about the differentiation between OCD and an eating disorder, or both, really understanding what's the fear that's happening so that you can get the correct diagnosis, you can get the correct treatment. Again, the treatments can look very similar, but I do think it's important that you take that step, make sure you feel very aligned with your clinician and the person assessing you so that you can get the care you need.
And somebody asked where they can listen to the podcast. So can you share where people can find out about CBT School, your podcast, and all that you're up to?
Sure. So that podcast that's coming out will be Friday. It's called Your Anxiety Toolkit Podcast. You can get it wherever you listen to podcasts. I'm not plugging the podcast. It's more that Caitlin spoke exactly, and Sharla spoke exactly about that scenario. Chris, the book, of course, and you can see a lot of my resources at cbtschool.com.
He's your spokesperson, Kim.
He is.
No.
Yes. And how about for you, Liz? What are some final thoughts that you can leave people with just to kind of boost them? We have the holiday coming next week. I know a lot of people are stressed. Like, what are some words of wisdom that you can provide for everyone?
I'm really grateful for Kim and her work and being here. And I just want to remind everyone that typically I'm seeing, at least, right, all of the OCD cases I work with, there's often comorbidities, right? These are complex illnesses where some individuals have OCD and eating disorder. There can be ARFID, there can be, there can be orthorexia, all sorts of things going on. There can be GAD, BFRBs, like all sorts of related disorders. And so as Chris said earlier, I just want to encourage you, talk to your clinician about everything that's going on. One thing I heard from someone recently is they were like, oh, well, my OCD specialist, like, I can't talk to them about things that aren't OCD. And I was like, what? And they were like, they even messaged me after, it was a friend. They're like, thank you for telling me I could. I was like, of course, right? Because if it's not in our wheelhouse, we should be telling you what we think it could be and referring it out, or otherwise in our wheelhouse. But a lot of individuals with OCD have comorbid, which means additional diagnosis outside of their OCD that play a role in their mental health and will play a huge role in their recovery. And we want you to get specified treatment for each. So just remember, just like ERP is specified for OCD, there are specified interventions for different diagnoses.
Well said. And I just want to thank everybody for joining us today. We had such robust questions. I just want to let Fitzpatrick, you're amazing, and Spence Robert, I put your questions on our sheet. Liz and I are here every single Wednesday at 9 a.m. Pacific and 12 Eastern, except the second Wednesday of the month. But we're here every other Wednesday asking your questions. Liz and I have a robust sheet of all the questions we don't get to that we have, and I put yours at the top. So I promise you we saw your questions. We just didn't get to it. Thank you, Kim. We got through all of our eating disorders questions except one. So we'll have to have you back now because we have one for you. And then don't forget to join Liz and I here same day, same time next Wednesday. Make sure to check out Kim's podcast. Go to iocdf.org for resources, and we appreciate you coming out and hanging with us today. Thank you so much.
Thanks, y'all.